All right. Well, good morning. For those of you that are here, it's mainly for the new fellows. Many of you have heard this talk so many times that you probably can recite it, but I have made a lot of changes to the slides, and you get extra points if you can find out what I actually changed. I wasn't going to include this because we have Dr. Rashbaum on the far right, Dr. Hochschiller there, and they're retired, but Dr. Ziegler's there, Dr. Heisey, and Dr. Lieberman. So they always say the fellows look so young, but the problem is that we're just getting older. So you can go to sleep, but just don't snore. So this morning what I'd like to do is go over the history of Texas Back Institute, research, and TBI spine fellowship. So it was in 1968 that Dr. Hochschel and Rashbaum formed the first back school in Dallas, Texas. They called it the North Texas Back School, and they also had physical therapy at that time. And then in 1982, I joined them after my fellowships, and we became the North Texas Orthopedic Associates. And in fact, we have a handle from that door. We had a beautiful facility. We had two buildings on the east side of Medical City, Plano. Those of you that go there, if you look to the right when you approach the building, those were both ours, and we occupied the third floor of the second building in the back. We had an outpatient myelogram, CT, and outpatient injection area, and we also had a full rehab. And our goal was to become the first and most academic multidisciplinary spine center. In 1985, we changed the name to the North Texas Back Institute, bringing the physical therapy and the back school under one name. And then we finally changed the name to Texas Back Institute in 1987. Dr. Sachs in 1985 joined us, and he headed up the TBI Research Foundation. And we started publishing landmark papers on discography. And again, this was back in the 80s, so we may not use much today, but it was then. And we as a group decided that research was very, very important, so we sort of tied ourselves and we invested about $200,000 a year for 10 years. And we pumped that into our research, and I think everybody that is in practice with us today benefits from what we had the foresight to do way back then. So in 1993, we moved from the Medical City Plano area over to the Texas Health Plano area right next to us, and we were on the far west side. We had 100,000 square feet, which was crazy. We had an Olympic-sized rehab pool on the first floor they subsequently filled in, and we had a full mechanics lab that had two state-of-the-art Instron machines and two PhDs. And if you think about it, kind of incredible for a private practice to do it, especially back at that time. So initially we believed in the hub and spoke area. We had many clinics, and we would refer the patients back into Plano here. And then in 2003, we moved over here, and we downsized. We took 50,000 square feet. On the third floor, we had a beautiful conference center, and we had a conference room like this, and this is really nicer. And we also had a cadaver lab that had 10 stations. And as we became more and more successful here in Plano, we attracted a lot of spine surgeons. So the last estimate was between 150 and 250, which is incredible for the size of the Metroplex. And then we migrated from the hub and spoke to the hub and hub, and now, as you know, we have clinics all over the place, and we have our docs also operating there. As far as our early research, we did some of the earliest endoscopic courses with Parvis Cambin. Yes, the Cambin's triangle. And this is before, Dr. Derman has really taken it by storm in endoscopic surgery, but this is nothing new. This we were doing since the early 1980s, and along with Medtronic and many other companies. We started participating in many FDA trials. We started out with electrical stimulation, and as you'll see later, we then migrated into arthroplasty. John Regan pioneered thoracoscopic surgery, so in 5 short years, we became the first and largest freestanding multidisciplinary institute in the U.S. We had over 300 employees. We had offices in Atlanta, in Houston, and we had rehab facilities in the L.A. area. We were rocking and rolling at that time. In 2000, Dr. Lieberman helped pioneer the development of the Mazor robot, and the rest is history. So we all know about robots today, and it's just something that continues to expand. In 2015, under Aram Hadassah's and Dr. Lieberman's leadership, we had the first spine gait lab in a private academic setting, and they published over 40 papers. Probably the most significant one was the cone of balance, but we've also looked at the improvement after doing decompressive myelopathy surgery. And then we're looking forward in the third quarter to finally starting our first and only spine simulation lab in the U.S. To better prepare you fellows and also let our doctors begin to practice new techniques on the simulators. So in the mid-1980s, we would have Friday morning conferences, and I've always wondered, how come we were seeing our patients come back after fusions, that is the Jason-Sakeman breakdown. And that sort of spurred us on, and we talked, very briefly about an artificial disc where many failed attempts early on. But then we heard about a German disc from Berlin. So we sent one of our former fellows, who then became a partner, and he was taking half a year off. And so he went to Germany and with our biomechanics research team, and they came back and they said, this is the real deal. So in the 1990s, we did some of the FDA required biomechanical testing. And I don't know that this would happen anymore, but nonetheless, Karen Buettner-Johns was a resident. And she was from East Germany before they united. And she was also an Olympic champion. So she was a superstar in academics and also in athletics, apropos of the Olympics today. So she also had her thesis that was translated from German to English. She visited TBI in the early 90s. And then in 2000, Dr. Blumenthal carried out the first Charité. That was in March of 2000, so 24 and a half years ago. And then Dr. Ziegler did the first ProDisc. And then we began our cervical trials, doing the ProDisc C study in 2003. We started our Center for Disc Replacement at TBI in 2010. We have a THCDS-CDR program where we bring in patients from all over the country and as well as the world. Dr. Shelik joined our team in 2020. And from 2000 to the present, we participated in over a dozen cervical and lumbar disc replacements. So why is our engagement in research and education important? Well, it establishes and maintains a leadership position. It creates the opportunity to work with the newest technology and allows our surgeons and TBI to be in the cutting edge, as we always have been. And it also promotes the science of spine by educating other surgeons in these new technologies and making the lives of our patients better, more importantly. If you look at our publications over the year, I just highlighted the totals. You can see that we've been very active, and special thanks to Donna, who's been with us since 1986 to the present. She's worked tirelessly. She's helped us with the publications and our talks throughout the world. You can see we've done over 1,000 presentations all over the world. So thank you, Donna. And here's some of just a few of our 99 articles published on cervical and lumbar disc replacement. And again, we've done hundreds of presentations all over the world. We've had also the best papers at the North American Spine Society for the past 7 years. We've had best papers at the International Society for Advancement of Spine Surgery, and also at ISLIS, and also in the cervical spine recently presented a paper in 2021. We've also had leadership roles, and I think this is important, at least for a group our size. Dr. Hochschild was president of ISAS, Dr. Rashbaum, Texas Pain Society, me, North American Spine, Dr. Ziegler, ISAS and American Spinal Injury, and Dr. Blumenthal recently was the International Society for Study of Lumbar Spine president, and Donna Omnes has been part of the board of directors of NASS for many, many years. So we started the fellowship in 1986 because I've always loved teaching, and it was basically a preceptorship. We could only take one fellow, just the three of us at the time. And again, this was on the campus just east of Medical City, Plano, or Medical Center, Plano. And the fellowship grew from one fellow from 3 to 4, and then to 5. And now we have such a large group with all of our attendings. We have really silos in every area of spine, in degenerative motion preservation, complex cervical, trauma, deformity, tumor, and MIS and endoscopic. And initially, I started the fellowship in '86. Dr. Ziegler joined me in '96 until 2020, and now Dr. Bellinger's our co-director, and Dr. Satin joined us after that. Kat has been our tireless fellowship manager, and Is she here? Yes, she's here. Okay. But anyway, so it's been a great run. You all have probably seen these plaques we have in the hallway. We have spots for you next year. They will be put up before you graduate. But so far, we've trained 142 full fellows. We've had a lot of part-time fellows from all over the world. We've also had 150 visiting fellows, and basically we have the best private and academic, or private-demic, as one of the fellow applicants had coined to me. And this is where all your co-fellows practice throughout the U.S. It's amazing. A lot of them are in Texas, but you can see they're smattered all over the country. So here's our class for those in the audience that haven't met Drew. And we have Claire, Emmanuel, and Chase, and they're all sitting there. If you guys would just turn around and show your smiling faces so they can match them up. And as far as the surgeons, so we have 22 spine surgeons, or 22 ortho and 4 neuro, and this shows the years they joined sort of the pecking order as we see and listed here. Dr. Rashbaum and Hochschild are retired. We also have a large number of non-op players. Dr. Block, who's a world-renowned psychologist, retired, and now he gave over to Diane Loke-Nickel, that actually was with us a while ago. I should have put those dates in there, Diane. And then we see all the PAs that we've had. So we thank everybody for being part of the team. And then our research team, most importantly, this is what sort of drives, TBI and drives our talks and helps us, gain prominence and participate in all the conferences throughout the U.S. and the world. These numbers are approximate, but you can see we do about 5,000 surgeries. We see 17,000 new patients, 35 established patients, but only a small percent, that is about 14%, undergo surgery. And 12% of the patients are from out of state or out of country. So now we'll go to the favorite part. This is the part where everybody falls asleep, but you guys will not. So this is the pearls and myths of spine surgery for a successful career. So the first pearl, and you really need to think about this, and I always tell folks this, you should never ask anybody to do something that you wouldn't do. And I even mopped the floor, and they took this picture of me one day, and I was kind of mad that they did, but it actually was a nice thing. And the other thing, when you come into work, you'll notice you walk by all the boxes and you'll see the people unloading. I say hello to everybody. It doesn't hurt to say hello and to smile. Everybody's part of your team. And I will guarantee you, if you do this all the time and one day you forget, people will come up to you and say, "Is everything okay?" You normally say hello. And that happened to me one day, and I was just worried about a patient. And my assistant came up and said, "Dr. Guy, are you okay?" I said, "Yeah." And she said, "Well, you didn't say hello to everybody." I said, "Oh, I was worried about a patient." So it really does make a difference, and it sort of sets the tone. So they are part of your team. So the supreme myth is that you will learn everything you need to learn in 12 months. No, you will not. It will take a lifetime, and much of what you will do 10 to 20 years from now, you won't be doing. Much of what you learn, you won't be doing 10 to 20 years from now. Spine is very exciting, and it continues to evolve, and with the technology, the AI, the robotics, the navigation, it's amazing. And people are living to be older, so we're doing different surgeries than when I first started out in the early 80s. We didn't have nearly the fixation that we have today. And you'll learn something every day, and if you don't learn one thing, you're just not paying attention. So that's why they call it going into practice. Whether you go into academic practice or private practice, you're going to practice your skills and you learn. So it's a transformative year, and I'm glad that Dr. Weaver's here, and I always tell, we don't have any neurosurgeons this year, but for the orthopods and neuropods, and especially for the orthopods, leave the brutane behind. This is a totally different skill set. We're dealing with nerve, spinal cord, and you have to be very, very gentle with these things. We want you to learn how to think critically and select your patients carefully. And we want you to read, and soak everything up like a sponge. Myth number 2, all spine problems are curable. You see a patient, you feel that you have to treat them, you have to find a cure for them. No, not really. And these are some quotes, one from a former PA, Joe Nagy. He's a lady, we can fix your toaster, but we can't fix your back. Now this one is from Jessica Kay, who's our PA, and she says, "Mrs. Jones, the reason they call it back surgery is that you keep coming back." And she tells the patients that to this day, but it's true. So a sobering reality is, and we think that we're all hotshots. We can do this navigation. We can put screws from the occiput down to the sacrum. But when we're operating for radiculopathy, at least in the low back, it's 85 to 95% chance of curing the leg pain, but it's not 100%. And we can improve axial neck and back pain. And it can be very, very satisfying, but it's not 100% of our patients. And we can do fantastic realignments of deformities, but it is complex surgery and not without significant complications. And unfortunately, what people don't realize, just like the aging of one's heart, you may get one stent, but you're probably going to get another one and another one and another one. And the same thing we see in spine. So, as I said, it's difficult to cure axial pain, but we can make it better. And we know from all the FDA trials that we participate in, particularly lumbar, that patients have a 90% average of a 50% reduction and a 50% improvement of their functional activities. So we've improved their quality of life. We haven't made them brand new because you can't make a patient brand new. So you have to talk to your patients and be realistic with them and set realistic expectations. And that is probably the most important thing that you can do, is set the realistic expectations. If you tell a patient they're going to go home in one day, they're going to go home in one day. If you tell them it's going to be a week, they're going to go home in a week. So what about size matters? I love this because the fellows say, oh my God, that's such a huge disc herniation, and we need to get that out. So this is one case where size doesn't always matter. So we operate on patients and not on their x-rays. Now, so you have to consider the whole picture. So if you read the radiology report, which I hate because it's not standardized, and I can't wait till AI gives us reports rather than having each radiologist give their own bias, because there's no two reports of the same MRI scan the same. So you have to consider the whole picture. If it's an 8mm herniation, well, how big is the spinal canal? Is some of the herniation or some of the signal really from epidural bleeding? Is there significant spinal cord compression? You'll get these reports, oh, horrible spinal stenosis, but the cord looks like it still has normal conformation. It's not squished. Still has its jelly bean appearance. So you have to look at these things. So a 10mm lumbar disc herniation, a 14mm canal, is very big, and it may be a problem. But a 10mm and a 24mm canal is not. But what about a 6mm herniation in a congenitally narrowed canal? That can be potentially dangerous. So these are just some pictures. So here is a 6 or 7mm herniation, somebody with a gigantic canal. The two pictures on the right are Dr. Shellock's patient that you cannot even see the thecal sac. I can't even, I tried to change the brightness and the contrast. You can't see the thecal sac. And she operated this gal. She thankfully had a great result, but she had all the classic signs of caudal quina. So the reality shows that large, small, and even extruded lumbar discs do respond to conservative care. They can resorb. And sometimes, as I said earlier, disc herniation may masquerade as epidural bleeding. Even cervical disc can resolve, and it's not unusual. In fact, those people that resolve will resolve within 4 to 12 weeks. So if you tell a patient just a few weeks into his cervical or lumbar radiculopathy, you need to have surgery because you could possibly get, permanent neurologic deficit, you're not really giving Mother Nature a chance to get it better. But from a recent meeting that I was at in Hawaii, this was presented by the Japanese, and this sort of explains it. It's very, very busy, but the basic thing is that there's expression of the MMP7, and this causes macrophage infiltration, and this is what resorbs the disc herniation. So it's this cascade of events that all the anti-inflammatory agents like TNF and so forth. So there is some science behind why these people get better. Yes, Blake.
I read something recently. The reason we have such an inflammatory response to the disc herniation itself is because the nucleus is actually enveloped in the annulus prior to the development of the immune system. So your body sees it as a foreign object. It doesn't recognize it as self, which is why the inflammatory response is so significant to even a small disc herniation.
Thank you, Blake. That's why it happens. And you can often see patients come back with say you saw them a couple years ago, they had a big herniated disc at L5S1, they got treated conservatively, they come back, and that's gone, and now they have a new herniation at 4 or 5. So the body does have the ability to heal. But the reality for disc surgery is that 85% of patients do great. It's not 100%. And why do 15% fail with the right operation? The sports study and the old Weber study from years and years ago showed that you still got 80% excellent outcomes with conservative treatment. So it's not 100%. And even in the elderly that we do all these corrections of their scoliosis, the complication rate is up to 40%, and the mortality in some cases has been up to 8%, but not at TBI, not with our surgeons. But still, it's major, major surgery, and you have to think twice and be absolutely certain this is what you need to do. Now, this is something that comes up all the time, and it's if we can't explain their pain, then they must be crazy. And we all see these patients in our clinics, and it drives us crazy. You know, you walk in, you say, "Hi, Mr. So-and-so, how are you?" And it's like, well, maybe they are, and maybe they're not. But the thing is that sometimes people get crazy because of their pain. And that's why I have to talk to the patients, talk to them about their family, they take any drugs, and their history can be complicated by their social, economic, and psychological issues. The wife hates them, they lost their job, whatever. And imagine if you were a heavy laborer. I know that if I was a heavy laborer, I would be on disability because my back is not great, and I just wouldn't be able to do it. And that's why we incorporated at TBI the multidisciplinary approach. That is, we have surgeons, we have physiatrists, we have PT, OT, we have our psychologist to help us manage these patients. And frankly, some people just have a very, very low pain threshold, but you still have to evaluate them carefully and treat all patients with dignity and respect because they are there, you are the doctor, and it's not for you to prejudge them. You have to make certain they don't have anything significant before you boot them out the door and say, "Oh my God, what a crazy patient." And we all do it. We do it, involuntarily, but you have to sort of reel yourself in and not get sucked into that. So this is why we use behavioral medicine, and Diana's taken over from Dr. Block, and patients are actually very receptive to it. And what we tell them is that we want to make sure that physically and psychologically you're ready for surgery. Just like space shots, they don't go up if one of the warning lights is red. So one of our warning lights is if they have depression, anxiety, or if they have other complicating psychological issues. And then a lot of times, once these patients are out of pain, they make a 180-degree turnaround, and they're really, really nice folks. And they're the types that oftentimes will bring you a little gift or make you something at home. So just remember that. So you have to treat everybody the same. So the other myth is you're going to learn everything you need to learn this year and make a great surgeon. Well, that's only partially correct. I mean, we can train you in all the current skills. We don't know what the future skills will be. And each fellow varies in how fast and how dexterous you are in learning newer surgical techniques. But the most important thing that we can teach you during your fellowship is surgical decision making. In other words, selection, selection, selection. We can train all of you. You all have made it this far because you are surgeons. You have the technical skills. But what we have to do is to make sure you have the mental skills to select your patients carefully and properly. And in practice, you'll see doctors out there that they are great surgeons. They never get complications, but their indications are horrible. And we see it every day in clinic with second opinions. Some people like to do 360s on everything. Month of back pain, you need a 360. They don't get complications, and they're really good surgeons, but they have no idea the proper indications. And then sometimes the opposite's true. We see people with really great indications that are not such great surgeons. So it's sort of that fine balance where you want to maintain great patient selection and have great skills. So the essence of your year here is to become excellent diagnosticians, to perform the right operation meticulously when indicated, and do it with precision. So when you're evaluating a patient, you have to see the whole picture. And most importantly, you have to listen to your patient. And you have to let them talk. You can't walk in and stand by the door and say, you have a big herniated disc and I think they need to have surgery. And I hear that very, very often from second opinion patients. They say, I said, well, what did he say? Well, he stood at the door and he said, I need surgery because the PA came in and examined them. Even if you have a great PA, you still need to touch your patient. There's something about physical touch. And it's just like during COVID when it was so crazy. Everybody was on Zoom. And we have a nice crowd here. We still have a lot of folks that are on Zoom, but there's nothing that replaces eye contact and that physical closeness to another human being that gives you that ability to connect with them. And that's one thing that I learned in fellowship. Dr. Wiltsey used to tell me, always touch your patient. And I learned that from Doug Jackson, who was a sports medicine doctor that would see 50 patients in the morning, the afternoon. And what he would do, he would take his cup of coffee, he would slink in, and he'd sit down, and he'd say, "Hey, Claire, how you doing?" And then he'd say, "Straighten your knee out." And he'd pat you on the knee and said, "Oh, you're doing really great." And he would walk out the door. He spent no more than 1 minute in the room. But what the patient remembered, he touched me, he examined me, and he talked to me. So let that be a lesson. So you have to correlate the patient's history in the exam. You have to look at all the x-rays and try to correlate them. And sometimes, it's not straightforward. You're going to have to do more studies. And even at that, sometimes you'll have conflicting studies, and that's where you call on your partners or you send text back to your fellowship folks. And a couple examples, we tend to concentrate on the really big surgeries. I still maintain that doing herniated disc surgery in the lumbar spine is one of the more difficult procedures to teach people to do it well. But sometimes you get an MRI scan with somebody with leg pain, and they say it's scar tissue, and then that's great. But anyway, sometimes it says scar tissue, but their clinical pictures are herniated discs. So you need to look at it more closely, and you're the one with the patient in front of them. Sometimes the MRI is normal, but on flexion and extension films that you might get in the clinic shows that they have instability. And then you also have to look at the x-rays very carefully. Don't go by what the radiologist said. As I said, no two radiologists will read the films the same. I use the radiologist to identify soft tissue tumors outside the spine because I'm not good at reading that. And I look for them to look for tumors that I have missed elsewhere. But I can read a lumbar spine MRI scan better than any radiologist. I don't care who they are because they don't know what we're looking for. So the one thing they have to be very careful of is a conjoint nerve root, and that can really get you in trouble. And we'll show you some examples. So we see this all the time. A PCP will get an MRI scan, and they send them to you. Patient has back pain, maybe a little bit leg pain. They come in to see you, get a flexion extension, you go, whoa. And you can see a little bit of degenerative spondy on the MRI scan, but this really brings it home. Here's one with the conjoint root. This is a patient of mine, and had a big herniation on the left side there. And but when you went down another cut, you can see the conjoint root, which means the two roots are going out the same foramen. And if you cut into that, it's a big deal. Now, sometimes a patient can have more than one problem, so don't overlook it. And this is a patient, Dr. Ziegler's, that had severe disabling low back pain, greater than leg pain. She had a grade 1 spine at L5S1. PCP sent the patient to Dr. Ziegler for decompressive surgery. But he listened and talked to the patient and learned that she had a aortic aneurysm and was evaluated by the vascular surgeon 4 weeks before, and it was about 3.7 centimeters. The exam was negative. But he looked at the x-rays and said, whoa, that looks a little bit bigger than 3.7. So basically, he astutely sent her back to the vascular surgeon. She had a stent placed that probably saved her life. And to quote this internist who lived around the turn of the century, that is the 19th century, not 20th. But he said, when the diagnosis is not clear, listen to your patient, and they will tell you what the diagnosis is. And too often I see patients where somebody didn't take the time to take a good history. I'm not talking about our clinic, outside clinics. Didn't take the time to take a good history, and the patient will tell you what's wrong with them. So you have to listen to the patient. You can't just say, okay, well, what was next? You got to sort of let them get it out. If they're talking forever, the little tricks to redirect them, but you have to let them get their story out to you. So here's another one that I had seen, and this patient had a Moby-C cervical disc replacement in 2018 and sees another surgeon, and he said, well, you need to have this removed to correct your kyphosis. Now, there may have been a little hypermobility at the level of the disc replacement. And as she was walking out the door, and she hadn't had any conservative treatment, and I asked her, I said, did you happen to have any of your pre-op films? So we took the pre-op films, and her kyphosis, her original kyphosis, was at the C4-5 level. and she had her surgery at C5-6, so that wasn't going to help that too much. So the next myth is that all technology should be quickly embraced. Wrong. And you're going to see this parabola, Scott's parabola, many times. If you look from left to right, it says a promising idea, everybody's all excited, everybody does it. And then all the way to the right, it says very old surgeons are amazed that they're juniors with rollicking stories of the old days, saying, oh, this was great. But the reality is that there's lots of new things come out, especially in spine. Everybody comes out with their newer Cades, their newer this, their newer that. So you have to be a little more careful. One of my mentors, Dick Rothman, was very conservative, and he said, I'm not going to experiment on my patients. I'm going to do what has worked for me, has been tried and true with low complication rate. It's not that you shouldn't try new things. It's just that you have to be a little cautious. So if you're skeptic about new technology, you'll be left behind. But I want you to understand that there's really nothing new in spine today that hasn't already been done in other industries. Okay, so translational science from other industries and area of medicine. There's nothing new under the sun. You might think you have a great idea. For example, the first industrial robot was developed by GM in 1961. And we're like, oh, excited, we got these robots in spine. 1961, well, it only took us about 80 years to catch up. And then the first remote robotic surgery was done in 2001 from New York City on a patient in Strasbourg, France. So it was a robotic laparoscopic surgery. And, we're like really cool. We can do all this endoscopic stuff, but this stuff has already been done. And if you think about the technology, for example, GPS was developed in 1973 by the military. And if the GPS satellites orbit about 12,000 miles above the Earth, and it's about 66 million feet above the Earth's surface, and it can detect, at least this is what we have today, it can detect a car moving 88 feet per second to an accuracy of about 6 feet. I mean, that's amazing. So you're talking about something 12,000 miles away. So don't you think that sometime in the future we could see sub-millimeter precision and we can do precise surgery? And, I think that in the future we'll have real-time navigation. Right now we don't. We can get flash images, but I think in some point it'll be real-time navigation, much like we have our cars. Because the one complaint that I hear is that, when you're doing decompression, like in neurosurgery, they'll use a lot of the ultrasound to check to make sure that they've gotten all the disc out. Wouldn't it be nice if we had real-time imaging to say, whoa, and I don't know what it's going to be. I don't know if it's going to be MRI scan or some newer scan. It's not going to be our current technology. It'll be something new. And the other thing to think about is that, with the advancement of robotics, and it is getting tremendously advanced, that you could sit in the same room, much the way the robotics is used in urology, in gynecology. They're doing it. We're not. So basically, surgically gifted surgeons will give way to computer-gifted surgeons. And fortunately, you all grew up in an age where computers are rampant. We depend on them for everything. And there's the new Da Vinci 5. Da Vinci was the very first robotic surgery where you sat behind the control panel, as you see on the right here. And basically, the instruments were controlled by these robotic arms. Well, there's a newer one out and now has force feedback. So if you pick up the tissues, you get the same sensation to just grams. And they have 3D imaging and very accurate color reproduction. So surgery with the aid of robots and real-time imaging beyond our current CT and MRI scans will allow us to do the incredible voyage. I don't know if you've seen that show where they miniaturize everybody, you go through the bloodstream. That's not so far away. And remember one thing, all the navigation, all the robotics, and the AI we use today is the worst that you will ever see in your careers. It's only going to get better. So this just talks about that there's a robot on the International Space Station, and they're talking about when will robotics become the standard of care for joint replacement. So again, you have to look outside of our field of spine to see what's happening there in terms of scientific advancements. So this is just sort of a summary of the things that probably only Dr. Ziegler and Blumenthal and I remember, but we've gone through all these different phases. Minimally invasive fusion are commonplace now, and we have all the different types of lifts. We had MIS disc surgery. We had lots of things like laser and iDet. But now we have the tube surgery. Endoscopic surgery is finally taking off, although it's still difficult. They still haven't mastered a way to train surgeons, and we'll talk about that in a little bit. Artificial disc, fortunately, we see the cervical artificial disc is quickly becoming the gold standard. Lumbar TDRs are a great operation. The problem is that it's all screwed up in terms of reimbursement. It's all screwed up in terms of the insurance, and it all started way back when there's competition between the companies, and lumbar disc replacement was given a non-coverage decision. I know it doesn't mean much to you, but that started back when artificial discs were first introduced. There was a big push for nuclear replacement. There's a little bit of resurgence with that, with this new one, PERC disc. We had the ability to do flexible or soft stabilization, and we did a lot of these, the DNAssist, but that's gone. There's some other versions out there, but not yet available. But biologics is really an exciting area. I'm not talking about the BMPs and stem cells, but we're also looking now, and this has been done in goats at the University of Pennsylvania. They've made tissue-engineered disc replacement. They've already implanted them in goats. They're hoping to get in human. So the cervical disc is very easy. What they do, they make a scaffold of the annulus, make a scaffold for the nucleus. They implant stem cells, and so far so good. At least in animals, large goat animal model that is. Gait analysis is really cool. We have a gait lab, but now you have wearables that almost can give us the same thing. Incredible. And you look at what your iPhone can tell you about your activities during the day. Well, they have now wearables that can give us almost the same information we get from the gait lab. Sorry, folks. But and robotics and navigation are here to stay. There is no question that what it's done, it's allowed an average surgeon to become a much better surgeon, because putting screws up at C1 and C2, that's not for the lighthearted. But with navigation, it is possible now that anybody can do it as long as they use the navigation properly. And that's something that when Dr. Ziegler and I, even Blumenthal, started, we did wires, we did some very rudimentary screws, but we couldn't really get them where it needed to be. There were some really skilled surgeons that could, but we couldn't do that. So this is an area that will continue to develop, and we'll see autonomous surgery and remote surgery with the use of robotics. Now, deformity surgery has really taken off. Everybody wants to do deformity surgery, except Dr. Shellock and I. But it is amazing the correction that we can do, and it's great. But the problem is that it comes with a lot of new problems. And for example, it's not like what Dr. Bellinger and Dr. Liebman do with their younger kids and the young adults over in Nigeria and Uganda. But what do we do about the 70 and 80-year-old? Do they need to be fixed all the way? And what about the difference in their sitting and standing alignment? Because a lot of the folks don't do a lot of standing and walking around. Do we need to be cognizant of that? And, is there a best correction for each patient? But I think that we will figure it out. And also strategies to prevent PJK, and I think they're slowly making progress. But I think big data and AI will help figure out really what the best strategy. So this is a whole new world for you all. So I think that although the sagittal balance correction is a big craze now, I think that in the future we'll have alternatives with hybrid reconstructions. And I'm not talking about doing artificial disc in the thoracic spine, but some type of flexible instrumentation that will lessen the stress and strain on the levels above and below and still maintain correction. I don't know what's going to be, but I know the engineers are smart. I know our docs are smart, and they will come up with something to lessen the impact of a long fusion from T3 all the way down to the sacrum. And I also think that we will be doing, and you probably will be doing, inside-out robotic-assisted decompressions with the real-time navigation that we talked about. 3D printing has become a big deal, and now I think it's DGen makes 3D printed patient-specific implants, and you can get them back in a matter of days for tumor surgery in the spine. You get a CT scan of the pelvis or wherever the tumor is before you do your resection. You get another CT scan, and within a week you have your implant that is perfect. There's no modification of it, and everything just fits, and you put your screws in, and it's incredible. And it's really a life-saving procedure for those patients that have these horrible problems. Robotic surgery is going to continue to expand. You're not going to have people like Dr. Bellinger that just he's got this ability to look at x-rays, and he can create the 3D image in his head, and he can make his hands move and put the screws in the right way. There are very few people like that. Not everybody's like that. He's going to resist robotic surgery because he doesn't need it. But for the rest of us mortals, this will really help us. We'll see biologic regeneration, and that's going to be helping to preserve our spinal anatomy and change our treatment drastically. What it will do, AI will make all of us better physicians. It will take the average guy, make him better. In particular, I can't wait till the GPs have it. So a patient comes in, fills everything out, comes to the GP, and with this patient with 3 days of back pain, that normally we get an MRI scan referral to the spine surgeon. The AI will say, okay, give the patient anti-inflammatory, tell them to take it easy for a few days, see them back in 2 weeks. If they're not better, start them in physical therapy, come back from physical therapy in 4 weeks. If not better, all right, then get an MRI scan, and then you can send them to the spine surgeon. So it's going to make all of us better in medicine. Now, it can be abused, of course. All right, so now we come sort of to the meat or towards the end. And, there's a certain amount of cockiness among some fellows and even some docs, and we get complacent and we think, okay, well, I've gone through all this training, I don't need to practice anything, I have all the skills and I don't have to practice before the surgery. Well, the answer is wrong, and especially now it's wrong, because you have to continue to practice your skills. And it's just like a musician in the orchestra. When you go to a symphony, you don't hear one wrong note, maybe once in a blue moon, but basically they practice for weeks and weeks so that they are all synchronous and every note is perfect. And that's why you need to carry out your surgery. Now, surgery is a little bit different because sometimes you approach anatomy that is not the same, it's different, and it just presents different problems. So you have to be able to readjust. But basically, you have the skill set to do it. So you too have to rehearse your surgery. And you'll become better and better as you gain more and more experience. But it doesn't mean you get complacent. So you want to study your pre-op x-rays and do your preoperative planning. With navigation now, there's a lot of programs that you can pre-plan all your screws. If you work with Dr. Liebman, I think he does all his the night before, so he knows exactly what screws, what length, what size, and he has his trajectories because he uses them as a robot. You want to think about the pitfalls that you might encounter, and that helped with the planning. For example, somebody might have really minuscule pedicles, and you're going, oh, whoa, we don't have a screw that small, but can I go to the medial bordering and break out the lateral border and still be okay? And also, you want to think about the expected pathology. Say you're doing tumors, and you want to think about the variations. And a lot of times in your early career, you have a patient with a herniated disc. You may have gotten a little lax, didn't realize that their MRI scan was over 6 months old. You're taking the surgery, and you get in there and take x-rays, you know at the right level, and voila, the disc is not there, because those macrophages ate it up because you didn't check a new MRI scan. But anyway, this happens, but you just have to make certain you're there and complete the surgery and the decompression. And my philosophy is prepare for the worst, and 99% of the time your surgery is going to go smoothly. Okay. And even at my age and all the surgery I've done, there's still certain cases that I get anxious about the night before, but I just go through them in my mind, what we're going to do and the things. And the most important thing is that when you're in the OR, you need to remain calm. If you get a complication, you just put a sponge or a patty over it and do what my old mentor, Leon Wiltsey, would do. He'd say to me as a fellow, he says, Rick, let's go look at the x-rays. I'm thinking, look at the x-rays, what are we looking at? We've already looked at the x-rays. But it was his way of sort of taking deep breaths or sort of rebooting his mental computer just to calm himself down. So The final advice is that you are embarking on a wonderful career. I only wish that I was 20 years younger, because the changes that we're going to see in the next 20 years are just going to be amazing. Spine has afforded me to travel all around the world, going to 6 different continents and making many great friends from all over. And now with social media, electronic media, and all the different social media things like WhatsApp. I mean, I talk to people all over the world on almost a weekly basis. And you'll have the same opportunities too. And in fact, each of you will be given the opportunity to join Dr. Bellinger and Dr. Liebman for their respective mission trips to Ethiopia and Uganda. And that will be a career and a life-changing experience. To the T, every fellow that comes back from those trips is just, they're blown away. And also what it does, I think it ignites something that's wonderful, and hopefully encourage you to do this, the future, because I think that like many things in life, you get more by giving than you do by receiving. And if you can help these folks that really live in horrible conditions compared to what we do, no air conditioning, walk for miles, if not days, to see Dr. Bellinger. It's just amazing. And I'm sorry I never went on a mission with you, Ted, but it truly is amazing. And you should go to the website. It's I think they call him Dr. Ted, but it's just incredible. So I went through that website just last week, and my hat's off to you, Ted. What you do is just fantastic. So finally, though, I want to welcome you to really one of the finest fellowships in the U.S. This is an important U.S. It goes important year. It goes extremely, extremely fast. Make the best use of your time. Ask lots of questions. Read as much as you can. Don't take the time off and say, "Oh, I'm going to run around and do this." There's always something to do and something to learn. You will never have another year like this, period. And what you get out of your fellowship is directly proportional to what you put in. It's like a computer, garbage in, garbage out. So we wish you lots of luck. It's going to go really, really fast, and it's going to be a great year. So we welcome you here, and thank you. I don't know if there's any questions from the fellows, but and I know there's no questions from the audience. By the way, some of our former fellows are sitting here, Dr. Shellock and Dr. Heisey. Dr. Heisey was one of the first fellows that we asked to join our group. He joined us in 1999. And Dr. Shellock joined us in 2007?
This is my 26th time.
Oh. And Dr. Duffy's also from her year. So anyway, it'll be a fun, great year.